This is the podcast for Basic ECG Interpretation Part 3. In this podcast, we're going to talk about atrial dysrhythmias and heart blocks. So, as you can see from the slide, there are 4 different types of atrial dysrhythmias that you need to know. Premature atrial contraction, which we've alluded to before with the early beat. Supraventricular tachycardia, atrial fibrillation, or AFib, and atrial flutter. All right, so here are a list of causes for atrial dysrhythmias. A lot of them are similar to the causes of tachycardia, all right, but can also include things like electrolyte imbalances, primarily potassium and magnesium, though sometimes sodium and calcium imbalances could cause these as well, but most of the time it's potassium and or magnesium. Myocardial damage, so from MIs, infections, fatigue, sometimes things like cardiomyopathy, so big floppy left ventricle sometimes can cause atrial fibrillation. So there are a whole bunch of different types of causes. All right, so we're going to start off with premature atrial contractions, are the easy ones. Okay, they're called PACs, and basically what they are, there's ectopic foci, so the cardiac cells, okay, a cell in the cardiac atria that doesn't normally create an impulse because the SA node does. For whatever reason, it decides to create an impulse and send an electrical impulse through the tissue, and it produces a beat, okay? So it comes in early, all right? So right here is the PAC. As you can see, it's even, and it should come about here, but it doesn't. It comes early, okay? But it's got a P wave, a QRS, and a T wave like every other one, all right? But it just comes in early. It's not life-threatening. It's really not a big deal. We probably have them all the time and no one ever notices. But it's something that could indicate an issue, all right? So it's something to consider, and maybe, some electrolytes should be looked at. Here is another pictorial representation. So here's the normal pathway of the SA node. Hits the AV node, disperses throughout the ventricle, and life is good. That are these normal beats, okay? Here is that atrial cell that decides to have its own way and kick off an impulse. And so it kicks off an impulse and it travels down, all right? And it comes in early than all the other ones. All right, so that's all that means. Really, we don't treat them unless the patient is symptomatic. Again, we can check electrolytes, so if we would need to replace electrolytes, we could. If they're really frequent, then we might try some kind of antidysrhythmic medication like amiodarone, metoprolol, or digoxin. Or if they're hypoxic, we could give them oxygen too, but usually they're asymptomatic and they don't even know they're having them. Now, supraventricular tachycardia, on the other hand, is something completely different. So, here we've got an irritable atrial focus, and it's stimulating the heart to beat at 150 to 300 beats per minute. So that atria, you think about this for a second. Every time the atria beats, the ventricle wants to beat as well. Excuse me. So if your atrial tissue is sending out impulses at a rate of 150 to 300 beats per minute, your ventricle also wants to beat that fast, okay? And that's a big problem because then we really have an issue with cardiac output. When you're looking at this strip, and I'm going to go to the next slide just so I can show it to you. When you're looking at SVT, this is what it is here, okay? You can't see the P wave. It's there, but it's buried under the T wave, so it just looks like one big lump, okay? It's regular, it's just very fast, okay? The QRS is narrow, all right? And like I said, the rhythm is very fast. So, again, you've got this irritable foci that's firing 150 to 300 times per minute, okay? And then the ventricle is trying to keep up with that. That's what the problem is. So here would be a picture of SVT, okay? So let's take a look at this, and this is a 6-second strip, so let's count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So 18 times 10 is 180. Okay, that's way too fast. I think the highest I've seen with SVT was 230. And let me tell you that the patient did not feel too good. All right, so causes of SVT. All right, here, most of your, like we talked before, fever, sepsis, caffeine, nicotine, stress, some pathomimetic drugs, hypoxia, anesthesia can do it. MIs can do it. And sometimes people just go into it and go out of it. So that's common as well. All right, so how do we treat SVT? Well, we can do some vagal maneuvers, okay? Because if we stimulate the vagus nerve, then we're going to stimulate bradycardia, and that's what we want to happen. We want the patient's heart rate to slow down, okay? So we could have them cough or gag. Gagging is not so nice, but it would work. Holding their breath and bearing down, so that's the Valsalva maneuver. We can do the diving reflex, and I did that in school one time, but immersing a patient's face in ice cold water is probably not the best way to treat SVT, but it's something that could potentially work. Because by immersing your face in ice cold water, it stimulates the vagus nerve and it makes your heart rate go down. Now, if the patient is unstable, we could do cardioversion. Okay, now we're going to talk about cardioversion later on, but cardioversion would be to get a patient out of an abnormal rhythm. Okay, defibrillation is when the patient's heart has stopped and we're shocking it to get it to start again. Okay, that's defibrillation. The big difference between the two is cardioversion is about 50 joules and defibrillation can be upwards of 300 or 360 joules. So cardioversion is a mild shock to get a patient out of an irregular rhythm. Defibrillation is a major shock to restart stopped cardiac muscle. All right, so that's the big difference between the two. We can give medications, so we can give diltiazem, which is cardizem, which is a calcium channel blocker. We can give that as a push bolus and then as a drip. Or we can give adenosine or adenocard. And we're going to talk about that in the next slide because it's a special little drug that we give a special way. And there are special considerations when we're giving adenosine to break SVT. If the patient is continuing to go in and out of SVT, we can do something called an ablation, where we will take them to the cath lab. We will find which cardiac cell is causing all the problems and zap it. So basically we kill it. Okay, so it stops putting the patient into SVT. All right, so adenocard. I just want to talk a little bit about adenocard. Adenocard is given in the ICU setting, and you should always have the crash cart nearby because it is considered to be a chemical cardioversion. Okay, we give a dose of 6 milligrams, then we can give 12 milligrams, and we can give a repeat dose of 12 milligrams if we need to. The biggest thing about adenocard is that it's only active for 1 to 2 minutes. So we basically get the IV as close to the patient as we can, as far as like close to the heart. And usually we'll put on a stopcock so that one piece of the stopcock is the medicine and one piece of the stopcock is a flush. And in this, and only this case, we shove the med in as fast as possible and we shove the flush in just as fast as possible right afterwards. Okay? Because its half-life is only like 10 to 15 seconds. So we want to get it into the patient as fast as possible. Now, the thing, it's a conversion medication. So it's used to convert SVT back down to normal sinus rhythm. Okay? It may result in 20 to 30 second period of profound bradycardia or asystole. Indeed, this is why you have the crash cart there in case the patient doesn't pick back up. Yeah, I had a patient one time, it was actually a coworker of my patient, who went into SVT whose heart rate was in the 230s. Okay, so we get the crash cart, we hook her up to the crash cart just in case. We give her the adenocard, and I'm like, you're gonna feel, a little funny. I said, but you should pick back up. Well, she had about a 30-second period of asystole. Okay, and at about the 20-second mark, she's like, I don't feel too good. She goes, I feel really nauseous. And I'm thinking to myself, so do I. I'm like, come on, heart, let's start back up again. And she's like, I feel really dizzy. And all of a sudden, I see this blip, blip, and I'm like, oh, thank God. Her heart started again because her heart basically stopped for about 30 seconds. And it was the scariest thing. Mine was racing and pounding, and hers had stopped. And she went back into a sinus rhythm, and life was fine. And all the while, I'm the therapeutic nurse going, "You're doing really good. You know, it's working well." And I'm thinking a little too well. And, you know, I'm like, it's going to be all right. And all of a sudden, you know, and in my head, I'm like, oh, please, you know, start back up. So Adenocard is an exciting drug to give. And sometimes it doesn't work at all. And sometimes you're like, you might as well just give saline because for all the good that it did. But the exciting ones come with that big, long period of asystole. And you're like, come on, heart, let's restart again. But Adenocard is the best used drug for SVT. All right. So the most common dysrhythmia is atrial fibrillation, or AFib. As you can see there, the majority of AFib patients are elderly, okay? And usually what brings these folks into the hospital is the fact that they're tachycardic. So very tachycardic, like in the 140s, 150s, 160s, okay? So they're just a step down from SVT. Atrial fibrillation means that the atria are beating so fast, okay, greater than 350 beats per minute is what the impulses are coming from these ectopic foci on the, or these cardiac cells, if you will, on the atria, okay? So they're beating at 350 beats per minute or greater. The problem with that is, again, is that those ventricles want to beat as fast. Every time the atria beats, the ventricles want to beat. So that's why the ventricular, you know, rate is so high, at least at first. The AV node, okay, like we said before, helps to slow down these impulses, but they're coming so fast and they're very irregular. So they're getting transmitted into the ventricles very irregularly. And so that's why the hallmark of atrial fibrillation is an irregular heartbeat. And basically what happens is that those atria are being, the cells in the atria are firing so fast that instead of the atria pumping, it just basically quivers, okay, or it fibrillates, or it quivers, just like Jell-O. The problem with that is that blood will sit in the atria and then kind of trickle down into the ventricle, okay? So your ventricle's pumping really fast. You're only trickling blood into the ventricle, so your cardiac output is extremely compromised when you have uncontrolled AFib or one with a rapid ventricular response, which is a heart rate greater than 100, okay? The other big thing with this blood pooling is the fact that it sits in the atria and it can coagulate, okay? So then if the patient goes in and out of AFib often enough, you have coagulated blood sitting in the atria, and it decides to go back to a normal rhythm, and then you're pumping out blood clot, okay? So you have PE, you have a stroke, you have a heart attack. So there's all different kinds of things that can happen because of the thrombus formation from atrial fibrillation. As you can see up there, that rapid ventricular rate decreases ventricular filling, and it reduces cardiac output, okay? So again, when the patient is in rapid ventricular response or uncontrolled AFib with a ventricular rate greater than 100, that is when cardiac output is reduced and you're going to have perfusion issues, okay? If the ventricular rate is controlled or less than 100, then you're not going to have the cardiac output and perfusion issues that you will with uncontrolled, okay? So I want you to keep that concept in mind. People live all the time with atrial fibrillation, all right? So it's not the trickling of blood from the atria that causes the decreased cardiac output. It is the rate of the ventricular response, or the heart rate, okay? So as long as it's controlled or less than 100, you know, and greater than 60, then we're in good shape, and that's exactly where we want it to be. All right, AFib can be acute, okay, caused by one of the things that we talked about earlier. It can be intermittent, or there's that word paroxysmal, okay, or it can be chronic, all right? So if it's chronic, we're going to want to make sure that the heart rate is controlled. If it's intermittent, we want to try to suppress that activity from happening. So we can use beta blockers, calcium channel blockers, those types of things to kind of keep the heart rate slower, to ensure that we keep that ventricular rate controlled. And if it's intermittent AFib, then that might just knock it out where the patient doesn't have the intermittent AFib problems at all. Like I said, it can be acute as well. So our goal always with the dysrhythmias is to get them out of whatever dysrhythmia they're in and back to a normal sinus rhythm. Okay, that's always our ultimate goal. However, it may not always happen. So, we need to make sure that if we can't fix the dysrhythmia, like AFib or aflutter, that we at least control the ventricular rate to make sure that we have adequate cardiac output. Alrighty, so here's a nice strip of AFib. Now, this is uncontrolled AFib, all right, because if this is a 6-second strip, let's count. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. So this patient's heart rate is 190, okay? So that is uncontrolled AFib because the heart rate is greater than 100. Now, the atria, all under here are like quivering, okay? There's no nice P wave in front of every QRS, okay? Matter of fact, there's none. Don't be deceived that there's one here, because there's not, all right? Or that one's one, that's not either, okay? It's just not. They're very uneven, okay? The rhythm is irregular, so that R to R interval, okay, is very irregular. Here it's really short, here it's really long. Here it's medium, medium, shorter, shorter, longer, shorter, shorter, longer. Okay, it's very irregular. You can't identify a P wave, and if you can't identify a P wave, then you cannot measure a PR interval. Okay, you're hard pressed to measure a T interval too. Now this guy's T wave is depressed, but other than that, because the T waves can be different sizes or can be different lengths as well because of the irregularness of the beats. All right, so again, here's the picture of normal pathway. And here's the AFib. So you've got numerous cardiac cells in the atria firing really rapidly. And here's a better representation of atrial fib. So you see they got a whole bunch of like little P waves, okay? That's all of these up here firing. So there's not one P wave for every QRS. There's a whole bunch of little P waves and they just fibrillate. So it's like a quivery line, okay? That is atrial fibrillation. So how do we treat AFib? Well, we can give them medications such as beta blockers, like the metoprolol, diltiazem, which is calcium channel blocker, amiodarone. IV amiodarone is probably the best drug of choice for AFib. When I worked in the ICU, it was about 50-50. Some physicians preferred diltiazem, some physicians preferred amiodarone. Some of it depended on the patient's past medical history, because amiodarone can cause some pulmonary issues if you're not careful. Anticoagulation, so the patients are always on a heparin drip, okay, and then are usually sent home on oral anticoagulants to make sure that they don't have any kind of blood clots. If the patient's newly diagnosed as AFib, we can, like I said, we want to try to get them out of AFib and back into a sinus rhythm if we can, so we might cardiovert them. We need to make sure that they're anticoagulated first so we don't put them back into sinus rhythm and then kick out a blood clot that might have been there. Usually we'll do a TEE. If you remember, that's a transesophageal echocardiogram first to see if there's clotting, and then we can cardiovert. Sometimes the cardioversion does not last and they go back into AFib, and then we just go back and usually use medications. Okay. There are times that we can do ablations to try to pinpoint where this atrial fibrillation is coming from. If the patient has recurrent issues of AFib, we could do an AV node ablation. So we'll basically knock out the AV node so these impulses cannot travel to the ventricles, and then you need a permanent pacemaker because you basically have knocked out your transmission of electrical impulses to the ventricles, and without those electrical impulses, well, then your ventricles won't pump. Your ventricles don't pump, and guess what? That's right. You don't have any cardiac output at all. So that's not so good. So if that's the case for severe AFib, then they would need a permanent pacemaker. Okay, so it's just a picture of ablation. They can do other types of treatments, something called a maze procedure, which is an open heart procedure, which you do not need to worry about. All right, so the next atrial dysrhythmia is atrial flutter. Okay, So while atrial fibrillation was numerous ectopic foci shooting out electrical impulses, or numerous cardiac cells, if you will, shooting out impulses, atrial flutter comes from one cardiac cell at a rapid rate. Okay? Again, the rate is 200 to 350 beats per minute. So if the atria is beating that fast, the ventricles want to beat that fast as well. Okay? So the big thing with atrial flutter and how it differentiates from AFib is that atrial flutter has the sawtooth appearance. Okay, these P waves look like saw teeth, and that's the biggest difference between atrial flutter and atrial fibrillation. Okay, so again, normal pathway. So instead of having all these different cardiac cells emitting electrical impulses as an AFib, it's one cardiac cell that is emitting a very fast and a very high amount of impulses. Like I said, 200 to 350 per minute. So each one of these is a P wave. Okay, but it's like a nice little saw, it's like saw teeth. Okay, and that is the appearance of atrial flutter. Again, when the ventricular rate is greater than 100, it is uncontrolled, or it is also known as a rapid ventricular response. Okay, or RVR. Once the ventricular rate is under control, then you should have normal cardiac output. Okay. So if your heart rate's above 100, your cardiac output is diminished, okay, or compromised. But once your heart rate is normal, even though you have a flutter or AFib, if the ventricular response is normal, okay, or your heart rate is normal, then your cardiac output should be pretty normal, and your blood pressure and your perfusions should be pretty normal. Okay. All right, so atrial flutter, what causes it? There are the causes up there. Hyperthyroid, hypoxia, heart failure, pericarditis, stretched atria. So again, you have floppy ventricles, which can lead to floppy or overstretched atria because you've got fluid overload. That can cause it as well. So there's all kinds of different causes there. Treatment is pretty similar as AFib. So you've got your digoxin, metoprolol, so your beta blockers, your calcium channel blockers. Brevibloc is another type of beta blocker. Okay. Amiodarone. So amiodarone is very highly used for atrial fibrillation and atrial flutter. Okay. We can cardiovert them. We can do ablations just like with AFib. So it's pretty much the same. But because atrial flutter only comes from one cardiac cell, usually if a patient has atrial flutter, they are more likely to respond to treatment either medically or cardioversion and remain in sinus rhythm for longer periods of time than in atrial fib. Okay? But the idea is the same. You know, can patients live with chronic atrial flutter and atrial fibrillation? They sure can, as long as the ventricular rate is controlled. All right, so this is just a comparison. All right, so here's atrial flutter. So you see like the sawtooth type of waves. Okay. And then here in AFib, it's just like a fibrillation. It's like a wiggly little line, and it's very irregular. Atrial flutter is irregular as well. Okay, so here's pretty wide, kind of narrow, pretty wide. Atrial flutter can sometimes look a little bit more regular. All right, but if you see these sawtooth appearances, it's an irregular beat, and it's atrial flutter. Just to make mention about junctional dysrhythmias, just because for completion's sake, junctional dysrhythmias are a problem with the SA node. So the SA node is not firing, so the AV node needs to take over. Okay. Now the AV node is past the atria, so you will not see P waves with a junctional dysrhythmia. All right, because the AV node is taking over. So when you have the SA node, then you're going to see P waves because that's your atrial kick, if you will. But in junctional rhythm, something's wrong with the SA node that it's not firing. Okay, so the AV node kicks in. Now the AV node only beats about 40 to 60 beats per minute, so it's slower. Okay, so junctional rhythms are usually slower. Okay, there's no atrial kick, so the blood will just kind of dribble down into the ventricles. Okay, A lot of times this is temporary and does not require treatment as long as the vital signs are okay. But the patient may need a pacemaker if it's too slow or it continues on and they get symptomatic. All right, so that's junctional rhythm. And then there are 4 types of heart blocks that I want to go over really quickly before the end of this podcast. So we have atrioventricular or AV blocks, and they're also known as heart blocks. Okay? So in heart blocks, the electrical impulses are delayed or blocked in the AV node, okay, or somewhere down the conduction system. The SA node functions normally, but for some reason they're blocked through the AV node. Okay? So causes of AV blocks can be too much beta blocker or too much calcium channel blocker, okay, or DIG. You can have previous MI issues, and sometimes they just pop up. Right? And there are 4 types. There is first degree, second degree type 1, second degree type 2, and third degree. First degree heart block is not a big deal. Okay? First degree heart block is just like sinus rhythm, except the PR interval is greater than 0.2 seconds. Okay? So every impulse reaches the ventricle, just like sinus rhythm. It just takes a little bit longer. So the PR interval is greater than 0.2 seconds. Okay? So again, this is what first degree heart block looks like. Okay? It looks just like sinus rhythm. So the only reason you would know that it's first degree heart block versus sinus rhythm is you would measure the PR interval and it's going to be greater than 0.20. Okay? Otherwise it looks just like sinus rhythm. Usually treatment is not necessary. Okay? We can adjust their therapy, decrease their dose if we're finding that this is the case. But the biggest thing is to monitor them to make sure they don't go into some other kind of block, which they can. All right, second degree heart block, there's 2 types. There's type 1, which is Wenckebach, and type 2. So in second degree heart block, you've got occasional blockages of impulses into the ventricles. Okay, so there will be times when you'll have a P wave and no QRS. Okay? So some go through and some don't. So when you're looking at these type of impulses, we're going to start with type 1. So type 1 is Wenckebach. So basically what happens is the PR interval gets longer and longer till eventually you're going to drop a QRS complex. So it's taking longer and longer for this impulse to get from the SA node through the AV node to the ventricle. Okay? So here's a normal beat. Okay? And now this one, your PR interval is a little longer. Okay? And now here your PR interval is a little bit longer, but it's still going through. And then you've got a P wave here, and this one's blocked. So you don't have a QRS and a T wave here. All you have is a lonely P wave. So it's longer, dropped. Now it can be longer, dropped, or longer, dropped, or, it depends on which ones get blocked. So it's not, always going to have 2 or 3 ahead of time, and then you're going to drop one. That's not always the case. But you're looking at this going, something doesn't look right here. This PR interval is longer, this one's longer, and oh look, this one has dropped the complex. So then the AV node has blocked the conduction of the electrical impulses from this. This happens often enough, you don't have any cardiac output here. Okay? So that can be a problem. Wenckebach is usually not too awful bad. We can usually treat them with atropine if they're symptomatic, so if they're bradycardic, we can do that. But most of the time, even type 1's not too awful bad. Okay? Type 2 is where you've got some P waves go through and some P waves do not. So in this case, here you've got a P wave, QRS, and a T wave. Okay? So it's a little bit, I think it's just the picture representation, but it takes a little bit longer sometimes for these these P waves to go through, or these electrical impulses from the atria to go through. Okay? But this one did, so you've got a QRS. This one did not. This one went through. This one went through. This one did not. This one did not. So until you get another QRS, you've got a long period of time here without any cardiac output. Okay? So these patients are usually extremely bradycardic. And they come in because they're having perfusion issues, like dizziness and syncope kind of issues. Okay. All right, so here's another looking one that, if you can see, this is pretty much every other beat. So you've got P wave, QRS, T, P wave, and nothing. P wave, QRS, T, P wave, and nothing. So those red lines indicate where there should be a QRS complex. All right. So if this was a 6-second strip, what should be happening is the patient's heart rate should be 1, 2, 3, 4, 5, 6, 7, 8, or 80, okay, which would be perfectly normal. However, the patient's heart rate is only 1, 2, 3, 40 because every other beat is not conducting and you're not having any ventricular response because it's being blocked. And if you don't have any ventricular response, you do not have cardiac output. So in this case, because the patient's heart rate really is only 40, then you're probably going to be hypotensive and have perfusion issues. So syncope, dizziness, that kind of thing. Okay. All right. So how do we treat it? Atropine, okay, if they're bradycardic, and possibly a temporary and or permanent pacemaker if necessary. You really have to watch these second-degree heart blocks because they really can progress into third degree pretty easily. And so you say, what's the big deal? Well, let me tell you what the big deal is. So, third-degree heart block is also called complete heart block. So there is a complete dissociation between the atria and the ventricles, okay? So the SA node is making impulses, okay, but they're not making their way into the ventricle. The atria does its own thing, and the ventricle does its own thing, and that's a problem, okay? So P waves are going to be regular. Now I'm going to slip ahead 2 slides to show you the strip, okay? I'm going. All right, so here's third-degree heart block. All right, so if you measured out these P waves, here's one, here's one, here's one, they come at a pretty regular interval, all right, for the most part. Okay. And then the QRSs just come about whenever the heck they please. So that's because the atria are doing its own thing, and the ventricles are doing its own thing. Now remember, okay, AV node only beats 40 to 60 times per minute. Okay, so it's going to be slow to begin with. So third-degree heart block is always usually pretty slow. And there's no association between the P waves and the QRSs. Because as you can see here, there's P wave, P wave. Look, there's a P wave here. Okay, there's a P wave here, here. You know, here's one that looks pretty normal, but you know, here's another P wave. So you're lacking a whole bunch of QRSs. All right. So if you went by the P waves about how fast this heart rate should be, it should be 1, 2, 3, 4, 5, 6, 7, 8, 9, almost 10. So this heart rate really should be 90, okay? And as you can see, it is 1, 2, 3, 30. Okay, so again, severely, profoundly bradycardic. I'm going to go back a slide. So very, very, very bradycardic. Okay, so it could be, you know, due to ischemia, some kind of funky conduction system problem, so an electrical system issue. Could be an injury from surgery, like from cardiac surgery. It could be a whole bunch of different things. But this is very life-threatening. Okay, if your heart rate's only 30, that doesn't do much for your cardiac output. Okay, so sometimes heart blocks can be caused by disease processes like Lyme's disease. Okay, Lyme disease can actually cause second and or third degree heart block. And so if that's the case, then we might put in a temporary pacemaker, which we'll talk about in another class. If the patient doesn't get any better, then we might put a permanent pacemaker in. Okay, atropine is not effective for third degree heart block. Okay, so this is the one place where atropine will not work. And that concludes podcast number 3 for ECG interpretation.